could you, there's seats at the table if anybody at the back wants to move up, because some of you I know have got things to say and I want to have the microphones available for you, so we could do that. Can I come now to you? Just introduce yourself and give us your take, please.
So it's nice to actually go after a few of the speakers that have actually set the scene. I'm Rizwana. I come from the South African Medical Research Council, and you know, to follow on what you've been saying, and especially where the last speaker just said, we are a human species, we are a single entity, and that we should address gaps that can actually enable everybody in ecosystems. And the previous speaker spoke about, you know, investment in converging thoughts around ecosystems and solutions for that. And so, you know, in South Africa and much of the global South, there's a paradigm and there's an inherent gap that we have to look at and we have to address. And there's a disparity, a very big disparity when it comes to a human species. Especially we see that in Africa, our populations in Africa have not been able to generate data on their genomics, well, much of the ecosystem has to be developed, has to be enabled from infrastructure right through to the basic science and generating knowledge on these populations. So you find that data is fragmented, disease patterns are understudied, and populations are underrepresented in genomic reference databases. With, I think now that we've calculated, given all of the flurry of activity in human genomics, I think that global genomic databases only represent now 0.8% of the African population genome. And this is now leading towards how do we enable an entire continent to improve healthcare when we are driving AI-driven, data-driven healthcare in the global north. So with that, I'd like us to think about how we redefine science, data, finance, governance, and converge to build resilient, inclusive health systems and healthcare initiatives. And at the South African Medical Research Council, we are trying to pioneer a national initiative where we are trying to converge all of the investment government has made in terms of our infrastructure, scaled programs that have in other sectors that are going to facilitate a national human genome program and the development of a national archive for our country as a health resource, so that we can create a unified area where we can find phenotype, genotype data and enable a personalized medicine ecosystem, a learning ecosystem, and an evidence-based medicine ecosystem. So I'm going to continue after those comments later. Thanks.
Thank you. So to keep the gender balance right, and I need to come to another gentleman who I heard speak earlier. Do you want to give your microphone there, have you? Introduce yourself. I mean, I already know you, but I think the world should know you as well. But I'd like you to, if you could answer the first question is, do you believe in convergence? This is not a religious meeting, by the way. Well, maybe it is, but perhaps go ahead, please.
Thank you. My name is Eliah Spencer. For the purposes of this meeting, I'm a physician scientist. I don't actually know the answer to your question. So no, to be a contrarian. I guess the opportunity, I mean, if we don't converge, we'll die. So I guess the opposite is yes, we'll converge. Can I diverge for my part and not say something I've said before? It's also something I'm uncomfortable with. I'm going to say I a few times, and I usually like to say we and things like that, but I'm going to talk about something I'm doing. But first, I'm going to poll the room. How many people think we could have universal, essential healthcare that covered 80% of the common diseases a person would encounter, could keep people alive for 24 hours, and we could do that in the next 5 years? Raise your hand if you think it's possible. 2, 3, 4. Okay, a few. How many people think it will happen? None. Okay. What's the cost of that in your mind? Is it $1 trillion, $10 trillion, or $100 trillion? Somebody say numbers. So if you do the math according to America, which is you take the amount of money we spend on every American and you multiply it by nearly 8 billion people, you get 14 to 20 trillion dollars. And that sounds silly. So that's not how we have to do it. The convergence of human need and really the democratization of medical knowledge through AI and resources. It makes it such that today we could have universal essential health care for everybody, and it's today. And here's how it works. I think people have a feeling of it. There are people wearing watches that do medical work. There are people in this room who have portable anti-shock therapies called EpiPens and albuterol inhalers, and we didn't really notice, but most of the things that doctors have that are special, they're not that special anymore. They've commoditized, they've come down in price, and usually the only blocker is either you don't know you can get it or you need a doctor to give it to you. Or, where's Matt? We haven't figured out the logistics to make the prices low enough yet. So a project in my lab, we started it with a challenge, actually at the X Prize, but this has been my career, which is what would it take to get universal essential health care for everyone on the planet? And so we did a deep dive on it. We put it to the X Prize, and in fact, the doctors at the X Prize just went and tried to assassinate me. I'm a doctor, and it turned out I was bigger than they were. It didn't work. And we said it picked up no traction. So we made the challenge that our students and our group of lunatics could make it such that everybody would believe it. And so here's the story. Over the last 2 years, we built a project called the Lifesaver. It's essentially a hospital in a backpack. You're familiar with these technologies. We put things like portable ultrasounds, little automated defibrillators. It turns out this thing that sort of overweight people use to help them breathe at night, when it has a special code called a backup rate, it's actually a ventilator. In America, they're expensive. Everywhere else, Singapore, where we found one for $40, high quality. So all the essential things you need to stay alive are small, portable, affordable, and the real problem is either not knowing you can get them. Once you get them, you need the doctor. No, not anymore. You can have embodied AI that can tell you what's in your kit, can tell you what to do. So we bought all this stuff, we put it in a backpack, we put it together, and then NASA heard about it and said, hey, you know what, we're going to Mars. And it turns out that's a place where we don't have a lot of doctors and we don't have a lot of other things, and we might need a little thing like that. And we had the opportunity not to go to Mars because Alon's got that wrapped up. But we went to what's called the Mars Analog, which is in the North Pole. And this is, I didn't get to go, my backpack and my robot dog got to. And we sent the Lifesaver to the Mars Analog in Devon Island in the North Pole. We did our probes, we proved it could work, and then catastrophe struck. And the actual mission required medical equipment that they didn't have. And so the oldest living person on this team, and we can't say this person's name, but you would know them, they had a life-threatening emergency, and they were supposed to be medevaced out of the North Pole until NASA heard, the NASA doctors heard what we had, and they said, hold on. And they diagnosed this person, treated this person for severe sepsis, and this person did not have to be airlifted a very long distance. And right after that, the team leader fell off an ATV and had another terrible accident. And the belief now, we're past that. And we made a little cute movie with a, like, you can dance party to it. And so for me, the convergence of need, technology, and knowledge is now here. And I think what I want to say is there are probably a lot of these, I didn't think we could have them. And we need to go move past that to like, we've got it, let's implement it. I'd also argue for this USAID thing, what's stopping anybody from filling that gap while 14 million Africans are dying? If you're really saying that, get the fuck off your seat and go do something. You wanted me to swear, and I want to be Irish.
First of all, the lesson from that is do never, ever travel with him, because it's quite clear that everywhere he goes, there's people of accidents or illness. So I'm not going your next expedition. Very dangerous. But what I would say is that your heart monitor going off? Anyway, what I want to say is convergence, yes, there are convergence at all sorts of levels. And I should tell you quickly that I also was chairman of a company that went for the same X Prize all those years ago. our role was from Northern Ireland, the University of Ulster, was to do, if any of you are old enough to remember Star Trek, not Star Wars, Star Trek. I'm certainly old enough. Remember Bones, the guy, every time somebody was injured, he ran this thing over them and he said, you need a new liver, you need a new leg, I'll get both, right? And we ended up being third, I think, or fourth in it. So we developed essentially a one tool to do that. That then translated into a defibrillator, which is a wearable defibrillator, which is the size, less than the size of a sticking plaster, now sold throughout the world. So this is where I agree that if you converge and you think differently, do not be hung up and the doctor has to sign off and everything. That's why more and more countries begin to use pharmacists, who are an unutilized resource, in my opinion. But that's another level of convergence. To try to keep us moving along, because we've got about 15, 20 minutes late, and I still haven't learned enough lessons from you as to what I'm going to say at the end of this, but that doesn't worry me. Coming to you next, and then we'll come to you, Petra. Is that all right with you? I'm going to give you 2 minutes notice of it. You're going to speak in about 2 minutes. Do you want to speak first?
After
Cece, please jump. Say who you are and tell us what your thoughts are.
Hi everybody, sorry, a bit late due to traffic. I'm Ziskos Lakidis, I'm the head of the lab services and biobanking at the International Agency for Research on Cancer at the World Health Organization. So my worry in the convergence is that we haven't really found the commoditization model. So even if it happens, we don't really have the way to put it into the market. So one of the examples that I can give you is the CT scanners. So they're getting smaller, more agile, more mobile, but the need is there. We still need upwards of 50,000 scanners in Africa alone, and we don't see them being produced at mass. And the reason is because once you have them and you have it installed, you still need to connect all the other dots in the system so that it becomes commoditized. It's a big issue of trying to push through the technology, but reach to the regulation so that the political decision is taken, so that it actually becomes meaningful and implementable.
No, just briefly, Matt, it's silo breaking is the word you're looking for. Silo breaking, yeah. And just on the money thing, listening to the cost of this and cost of that, you may or may not be aware that the cost of global fossil fuel subsidies is $7 trillion a year. So, my mantra is the problem's not the money. It's loads of money. It's not being spent on the right thing, and it's certainly not being spent or prioritized. $7 trillion per year. Think about it. And I would argue that Mei Lin has educated us a lot on stuff like digital public infrastructure. And Raúl said it's all about the data, which I completely agree. But in the area of data regulation, we are seeing very, very strong divergence. There is no convergence. There's the EU regulating trying to regulate for the rest of the world. I mean, CILSS and Rita and others know a lot more about the impact of this, but it is diverging increasingly, and many of the communities that are being impacted by this don't even realize this. And this is a huge impediment in the health space, in terms of access to data, use of data, and of course, these devices are data enabled eventually, yeah, but eventually, and as well as the development and evolution of drugs and therapies, all data enabled, but the regulatory environment is diverging and making that more distant rather than nearer. Thank you, Brian.
So we're beginning to get the discussion going, and we're learning a lot, particularly the way people think and what they mean by convergence and divergence. So that's the whole point of a discussion. No one's right. Everybody's partly right, and we have to work out then at the end of this meeting what we do next. So I'm going to come to you, Petronella, if you don't mind. I did give you a 2-minute warning. So first, the question of convergence. I've heard you speak a couple of times over the last few days, and I can see where you're heading in your country. Convergence, what do you think?
Okay, Thanks, Brian. So I wasn't expecting to speak in this session. That's why I delegated Rizwana. But I just want to take it from a different angle, because I'm listening to what Eli is saying and what everybody else, quite a number of the colleagues around the table have been saying about just how many solutions there are out there, and the fact that, you know, we have so much going that we should not be having 14 million people dying and, you know, all the other problems. And I'm also just thinking back to my own village in Zimbabwe, for example, where I come from. And I realize that we can have, you know, all these magnificent solutions, but if we don't, one is in a context where there is bad governance, poor leadership, and weak or a terrorized civil society, then we will never get the kind of, you know, impact that we want to get in healthcare, but also in all the other dimensions of sustainable development. So I think I just want to echo, but without the anger, what the lady that was sitting here said yesterday, that we need to talk about all these other things that are not necessarily, you know, directly related to science, related to health, but that actually affect the kind of impact that is to be held on the ground. And then also, yeah, just maybe for the private sector to also, in terms of the solutions and the modes of delivery, to consider how to still get these solutions to people where the government itself is actually not an enabler, but a disabler, but still there is a market on the ground. And, you know, the solutions, if affordable, people would be willing. I mean, anybody can pay everything they have for health. So there is always going to be a market, but sometimes it's easy to forget that, you know, there's a whole lot of other factors that prevent impact. Thanks.
Thank you. Just let me talk briefly about Zimbabwe, or Zim, as I learned to call it in Africa, Zim. What's really interesting, one of our members there, Dr. Admore, is trying to create the connected smart village when you talk about villages, because this is about enabling them with your infrastructure so that those people in villages have Wi-Fi, for example, telephones and so on, and they are then able to communicate without walking long distances to see a doctor. They don't actually need to see a doctor physically in many cases, and therefore they can continue to have a safe birth, et cetera, et cetera. And what we're trying to do with our partnerships around the world with, for example, the GSMA, who represent 800 telecoms companies around the world, we're trying to encourage them to look at, for Africa, for example, of a connected village concept, which says we need to get Wi-Fi into that village. Look at what they've done in Rwanda, where by December this year, not in 10 years' time, they will have what they call a digitized population, right? This is where they have understood your point, really, about a digital infrastructure. Is it perfect? No, but it's a lot better than it was before. And I think that's important. To your point about scanners and things, one of our other members in Africa, Baby Checker it's called, you may not have heard of it. It's where small handheld ultrasound devices are in use in villages to check on pregnant ladies. And those scans and so on are sent through the internet directly to, you don't need to walk 4 hours to see the doctor. So the fact you have more safe births, the fact that those people grow up and are productive, because people forget about the return and the productivity gains you get from that population. There are solutions everywhere. I agree with you. I think we sometimes don't look at them. We're too structured. We're too institutionalized. I say this, I don't think I am, and I'm determined not to be, and I don't want any of you to be, but I think all the points you make are good ones, but we can't allow any concerns about those to be the overriding factor. We have to look at the bigger picture and say, we need to make this work. We'll come on to financing and return on capital investment in just a minute, but I want to bring another person in. Sylvain, do you want to speak, please, from Burkina Faso? Please, just introduce yourself.
Thank you so much. So I think that the topic we are discussing is interesting for our countries particularly, how to make a decision or how to guide policies. I think that for us, we need really to have science-based decision to guide policies. And for that, we need data. And I know that in the region where I'm coming from, and mainly from my organization, we have different experiences on that decision, science-based decision. I can quote the example of pesticide registration. We have a common regulation where we used to collect data, scientific data, the effect on environment, the effect on human health. And then policymakers can make a decision to restrict or to ban the pesticide. Sometimes if you have the development of resistance in pests, you need to have scientific data before to decide. So we have this kind of experience. That's why I believe that we need to have this convergence. But so people, the policymakers, they have to look at scientific data and guide their decision. Thank you.
Thank you, Sylvain. Elena, would you like to, if you can find a microphone somewhere, and just give us your reaction, please, to this?
Can you hear me? So hi, I'm Elena Ladas from Columbia University. So I just jumped in about the half hour ago. So for one, yes, I agree. I do think, you know, kind of like you even diversify personal portfolios, and when I'm looking to support my global program and domestic program, there's a diversification of funding, you know, and especially this has been important being at an institution that is taking hits from all different sides these days. I do agree before that data is essential, but I often find data also can be limiting. I can talk to ministries of health to the cows come home about how a malnourished child will die, you know, and not be able to receive cancer therapy if they're not sufficiently nourished. Death rates, I don't feel, are the numbers we need. So we need to be more strategic about what numbers. Cost is always, you know, essential, but that often doesn't. I would say one other thing is, you know, this whole meeting, I've heard the word innovate all throughout. We talked about this a little bit, but I really think that as we converge and come together, it's not necessarily about innovative solutions. Yes, I'm a scientist. I love innovation. I love, you know, the science I do. It's interesting. There's solutions to be had, but not everything. When it comes to saving lives, not everything is about a new fancy solution. Sometimes it's just access. Sometimes it's really basic. And I think that we need, as we get, you know, one of the challenges I think is when you're looking at donors or prospects that want to invest in this, they also want to invest in something that's sleek and sexy and new. And, you know, again, a lot of our solutions aren't, but do save lives. So I think that's probably a big challenge we have ahead of us.
Thanks very much. I'm going to say this, and this might again be controversial. You and I talked earlier about innovation. I think it's the most overused word in the English language, maybe in other languages as well. I just think, why the heck does everything have to be new and innovative? It's a buzzword that everybody uses, and I often wonder what the heck it actually means. There's a whole lot of things invented. We talked about patents and IP and so on earlier, about the way they're then wasted and nobody utilizes them. There are a lot of things we already have. We should use what we have. I run some companies that are innovative, and we use it as buzzwords and marketing words and to raise money from private sector people and so on. But for God's sake, just let's have a think about what we mean by that. So that's one of my hobby horses. That's English for one of my rants. So I'd like to move on. Could I ask you, I think it's Carthia, is it? Could you like to give your input, please? Just say who you are and give us your response if you can, without knocking all the glasses over. There you go.
Hi, I'm Karthi, and I work for an organization called Tawaki Health. We're a regional advocacy organization working across Africa for more equitable health policies and financing. I completely agree with everything that was shared here and the 4 pillars that you mentioned for convergence. I think we definitely have to converge. But I would add a 5th, or maybe like a cross-cutting channel, I don't know what you want to call it. I don't think it's particularly controversial. I think it's something that most of us sitting in this room would agree with. But I think it's something that's not articulated often enough in this space, and that is communities. How are we converging with communities, people as not just sources of data, not just included in validation studies, but as co-creators of solutions? And I think if we are able to include communities from the beginning, convergence will happen naturally, because people, they know what they need, they know how solutions work, they know that if an innovative machine is coming into the clinic and the clinic doesn't have enough power outlets, they can say no from the beginning. They can co-create that solution with you. So I think when we're talking about these, we have a tendency to naturally institutionalize, I think all of us, regardless of our best interests, but if we are able to include communities from the beginning and have that be a core part of how we work, I think that will change a lot of things. And to your point about funding models, I do think there are examples that we can look at, like the Global Fund, that has a more systems approach in its funding. Even though it is the Global Fund to fight HIV, TB, and malaria, I think it works much beyond the name to really strengthen health systems, to prioritize digital health programming, to prioritize community rights, gender, human rights in its programming. And its governance model includes the implementing country, the donor country, communities, implementing partners. And of course, it has its flaws, but I think it is a really good model that we can work on. And as we are talking about where does global health go in the future, it is something that we can build on. Thanks.
Thanks very much indeed. I'm going to come to you, Rita. If you could, you're from a research background, so if you could give your input to that. And then I'd like just to give you a warning. We're only about 10 minutes left, so I've still got to be educated for my 2 or 3 minutes at the end. And then I'm going to come to Pleasant Reese, our Deputy Chair, to talk about communities, just particularly our ecosystems and so on, to reflect on what Carthy just said. Over to you,
so very, very quickly, conscious of time, Rita Lawler, Cancer Research Centre Manager. I, in a past life, was a computer scientist, so I completely understand the value of data, but I'm going to throw out and play devil's advocate. Has anybody actually tried to put some different data sets together? It is an enormous nightmare. It really is. And it brings me to the actual point that came to my mind at the very opening of the session when you talked about people working in silos. And I don't think it's that they intend to work in silos, and I do hate the word silo, but it does describe exactly what's happening. I think sometimes they think that they're not understood, or they don't know how to explain, or because they think others won't understand, or there isn't time. There's an awful lot of that going on. But if you use the data as the example, even within the same profession, and again, professional defect, work in pathology, try and ask 2 pathologists to write down the same diagnosis. You'll get a very different descriptive. It'll mean probably the same thing, but it will be very different in its look and feel. And that's within the same profession. Then you introduce different professions. Even within the healthcare system, they're not going to be able to talk to each other. So if we're looking to converge and start to bring in other professions that are not in the medical healthcare, we need to be speaking the same language. And I don't mean the languages that are acknowledged worldwide. I mean, we need to be communicating. And I will use the example that I've used since 2011 with regard to the European Commission legislators or regulators when they drew the first draft of the GDPR, which is the General Data Protection Regulations for anybody that doesn't know that horrible 4-letter word. They stated that scientific research was not as important as public health. Let that sit with you for a moment, just so that you can understand. That's where, if we want to converge, we need them to be understanding that scientific research is important, public health is important, how we can affect the financing of. So we need to find a way to communicate with each other. Convergence or not, we need to be trying to at least speak the same language or have an AI bot that's interpreting for us. That's all I have to say. Thank you.
Hear, hear. Maybe the secret is we leave it to AI and we all just relax. Have you noticed, by the way, many of you go to Zoom meetings these days, and there's so many blank screens because Read AI or some other artificial intelligence is actually substituting for the person who couldn't make it to the meeting, and we all read our AI notes afterwards, and begin to think that human beings will stop speaking to each other. That's a possibility as well. Bledden, I want to come to you and just talk about, I want to particularly the communities bit, and maybe a word or two on convergence, please.
So when we started the ECH Alliance, we naively thought we were breaking down barriers between public, private, and voluntary, not realizing that we had to break down those barriers in each of them before we could communicate and connect the three. Our vehicle for doing this was to create communities, but communities of all stakeholders you need to transform health and care. So the system, as in the ministries, the hospitals, primary care, regulators, and then industry, and any industry involved in healthcare, so not just hospital providers, but social care providers, pharma, tech, med tech, and then industries nobody knows are involved in healthcare, like energy, automotive. And then we put in the universities, and the universities give us three things: the teaching schools for expertise, the engineering schools for innovation, even though you don't like that word, and the business schools for ROI and other analytics. And then we throw in local authorities and housing, and we're looking for the voluntary sector, so everything from a two-person drug counseling to a national charity, International Diabetes Federation. And those communities are about transferring best practice, lessons learned, and failure from place to place. So they are geographically based. So they're either regions or entire countries. And we started with 4, and we weren't sure whether it would work in Europe because of the different funding mechanisms for healthcare systems, and also the legal structures of healthcare systems were very different. But today we have around about 85. And I suspect all around the world: North America, South America, Asia, Europe, Africa, and India. And I think we could easily double the number that we have if we had the resources to support them. But what we have found is that fundamentally people are decent. They want to help each other, and the organizations in our communities will try and help each other, and they'll do it for free. So if we're trying to work on, for instance, menopause, and we're looking at some of the treatments and the planning for it, one ecosystem will give their work to another ecosystem voluntarily. And I think that the power of convergence is to actually realize that we can really get people to work together in ways that we can't really imagine that they would do. But if you think about your circle of friends and what people will do to help each other when things go wrong in families and things, it's no different, really. So that's the basis of our community. And I would just say a couple of things. So on data, I think the thing that we sometimes forget is the data quality. So that actually when you get scientists in a room, or you get certainly people who are involved in running healthcare systems, I invariably find they attack the data. And so part of the problem is that data quality, and there's a need for cleaning data and actually improving, and so just missing fields of clinical data and data sets. So sometimes the data quality is ignored. And the other thing I'd say is data scientists, so that the tech companies, whether it's Google, Microsoft, Amazon, are hoovering up the best data scientists, and public health and healthcare systems need data scientists. So there's I think for universities, training the future data scientists and actually trying to hang on to them in systems is going to be very important. And then final comment from me, 3 enablers listening to all of you. I just think we have to have trust. We need to realize that part of making this convergence work is around building trust between the subjects, the sectors, the people. And then it's about ambition. So I just think that we shouldn't be negative about this. We should think big. And then the final thing for me is we need energy. So there are so many reasons why things won't work, but we have to sort of just run at the wall, have a bit of concussion, get back up and go at it again. You know, it's requires determination and energy to do what we need to do.
Thank you, Bledden. We're now at the stage where we have, according to Declan, my mentor here, about 4 minutes left, so I won't take 5 minutes, obviously. I'll take about 2. First of all, it's very interesting. I really learned a lot again. I always learn a lot. The problem is you learn so much, you then, how the heck does all this fit together? So I tend to be quite practical. My wife does not agree, by the way, but I think I'm very practical. And that is that I think the practical step we are going to take as the Global Health Connector is this. On the 23rd of September, in New York, during UNGA, we are having a Convergence Day. It's already set. We're going to have it, whether anybody likes it or not, because we do. But I would invite all of you, if you're in New York, and many of you know are going to be there, to come and join us on that day, because this will be the next step in the journey of trying to get convergence. Let me tell you what I think is missing out of this conversation, and that is the fact that yesterday many of us attended a capital markets session, which only Declan would have thought up. And I think it was one of the most interesting sessions. We now find there are solutions, there are financial solutions. Private sector looks for return on investment. People said, stop talking about aid, start talking about investment. Rita, I think, said that yesterday. The reality is there are pension funds throughout Europe who have huge amounts of money to invest. They get a return over a long period of time, not a short period of time as some banks would want, but actually they're already financing through pension funds opportunities and real projects in different countries across the world. So they see a rate of return. They've done all their risk assessment, done all of that. So as you said earlier, money is not the problem. It's the convergence we need to connect some of those financing mechanisms to our needs. So we have to, as a group, be able to do an elevator pitch to say, I've got this, you should invest in this, right? You will get a return of X, Y, Z. You have to speak the language before the banker will even listen to you. We all do that when we're looking for an overdraft or a mortgage. We need to, as a group, and that's one of the elements that will come out of convergence. We will have financial people at that day. We need you to join us. Second and last bit is, we will produce from this meeting a series of outcomes. We will send them all to you. This community exists already. We need you to continue to input between now and September. It's not, let's wait for the next event. We will produce that in the next week or so. We need you to engage with us and correct us where we go wrong, give us your additional thoughts, focus on the things you're interested in, because it is the collection of each of those ideas. We won't solve everything, but at least we're on the road to try to solve them. So I'm grateful to you all and grateful to the people online. I'm going to finish off with passing over to Declan, who'll give us his closing remark.
No, just really to say thank you very much, Brian, and to all our speakers. And yeah, we learn a lot, and I'm fascinated but very ignorant about the convergence between Western finance and Islamic finance, for example. You know, and I learned yesterday that Islamic financiers don't charge interest. You know, so FYI. So I mean, there are many conversations to be had. We can still learn a lot, but of course there is an urgency. There is, and there are many impediments. And as I said, you know, huge opportunities for convergence. But let us not be ignorant of what Rita has told us. And I think divergence in this area happens because there is no transparency, there's no communication, there's no outreach, there's no inclusion. So we have to be aware of this. Brian, thank you very much. Photo, please, and thanks to all our speakers. If I could have everybody up here, please. Yeah, photo. And our photographer could come this way.